Hello again. Like to invite Dr. Kubota that will present compliance. Thank you. You have the floor. It's a great honor to be here. This is a very interesting topic with several perspectives and with the results here of the studies. I've changed a little bit the topic of my talk, but it's cranial spinal compliance in chronic issues. Acute phase, ICU. But that's a fact in the neurologist, neurosurgery. There are a number of diseases with CSF. I would like to reinforce the epidemiology of age-specific global epidemiology of hydrocephalus systemic review, which is associated to ICP increase. That is a frequent one. It happens with 85 to 100,000 subjects and above 65. And the prevalence may be above 100, 150 subjects. That is a condition which is prevalent in underdeveloped countries in Latin America, Africa, and some other regions in the Eastern countries. Normal hydrocephaly. General population sees that as a quite infrequent condition, and the prevalence may take place above 6% of the population in this age range. Another frequent condition in the neurologist is the craniopathic condition, women, young, fertile, with an increase of ICP, which is not justified by anything else. No tumor, but yet the ICP is increased. Pathophysiology, liquor pressure. And that is a disease which was considered for quite a long, not common. And there is an increase of the prevalence of this disease, where in the past years, there was six-fold increase of this disease prevalence in the UK, especially among women due to obesity pandemic. A significant increase of those people with an increased BMI. Intracranial spontaneous pressure with those that have a reduction, pathological reduction of intracranial pressure. And we believe that that is related to meningeal fistula, which is that area that involves the cranial-spinal compartment. It reduces intracranial pressure, including refractory cephalea. And that is extremely difficult to be diagnosed. The average of the beginning of the symptoms until diagnosis, it's over 1 year. And the initial diagnosis in most cases, in 90% of time, is a wrong diagnosis. So that is a condition of CSF that represents a diagnostic challenge at neurosurgeons' offices. CSF dynamic may be studied based on 3 indicators. But the main indicator applied in clinical practice is the liquor pressure, with some limitations. From an outpatient perspective, this information cannot be easily obtained. This is a context of a patient in an acute phase. We expect the pressure to be normal, but as I was saying, this is an indicator with some limitations. On outpatient, there are some issues such as to reach that due to a cervical function, where we reach the liquor space and we measure patient's pressure in a side position with some risk of complications. That does not allow to study the fluctuation of pressure throughout hours and time, but not all patients may carry out that procedures. Patients with coagulopathy, they cannot perform it. Pressures may be subestimated if there is any anatomic changes that will interfere. You do not communicate pressure, and maybe overestimate if patients are too anxious with too much discomfort, increases intrathoracic pressure, and that will underestimate it. But that's not just a procedure limitation. Not always we see a direct correlation between the liquoric pressure and clinical outcomes which are significant, which have its significance. The pressure distribution, traditionally speaking, we believe that we have 100 centimeters of water, but a significant fraction of the population will have a pressure above 20 millimeters of water and no disturbance of CSF. Obese patients, but they may have that increased pressure, especially 20 or 30 centimeters of water. Idiopathic intracranial pressure, if the clinic is not well established, CSF ranges in intermediate range, and that is indeed a problem to some patients. Another condition which shows a limit of the biomarkers, which is the lumbar pressure, is the normal pressure hydrocephalus. You have a ventriculomegaly in the absence of obstruction of the ventricular, and yet patient's ICP is normal. But the pressure is still normal, and what's happening? We may raise a hypothesis that there is increase a CSF dynamic alteration, or maybe a atrophy of the ventricular mass, maybe cerebrovascular diseases or Alzheimer's disease, which have a component that will interfere in most patients with a condition like that. Diseases may collaborate to a condition like that, but you may not justify that fully. As in their MRI, there is no global brain atrophy, but there is enlargement of the ventricle and the vertebral sulcs, they are comprised. It seems that there is something growing from inside out, and yet patient's pressure is normal. If there is a shunt between the ventricle and the peritoneal, reestablishing a local pressure, we see a clinical improvement in around 50% of all cases. That shows that there is a CSF issue and that deserves some treatment, and that shows that there is some limitations in the CSF as a biomarker. And last, there is another very interesting find, is spontaneous CSF. Despite the name high potential spontaneous CSF, there is a presence of 1/3 of patients with normal pressure, and 3% they have increased pressure, and that is the disease itself. And we discuss if the terminology of the disease should change it or not. Pressure not always is related to a diagnostic clinical outcome. So what now? What can we do? What additional information may we get that will help us to treat patients like that? Well, if we go back to CSF parameters, we have to consider some other additional indicators, such as compliance and elastance for the cranial spinal portion. There are some studies published 10 years ago, and why don't we apply that in our clinical practices? Because apparently for those patients who are not admitted in the ICU, that is quite invasive. It's an invasive procedure, and Professor Mascarenhas, he's so bright in taking this technology to brain care, and that information becomes more accessible, and it gives opportunity to get more brain from a clinical utility. Compliance, and its more basic concept, is a volumetric variation and divided by the pressure, and elastance is exactly the opposite to it. How can we translate it to accommodate or to compromise volume changes without significantly change pressure? There will be those patients where compliance is reduced, and small volume changes will compromise it. And there is also the reverse. We have patients with an increased compliance and a decreased elastance to generate enough volume. What are the parameters then? We may directly assess compliance, or there is another frequent way according to the literature, which is pressure and volume relationship. Volume and pressure, they follow this increasing curve. If we follow this log and mathematical equation, there is a straight line. This is the index, pressure and volume, which is directly related to compliance. There is another practical manner, which is to assess morphology of the variation of ICP according to the late cycle pulsation. If you have a late pulse, you have a blood flow to the patient's skull that will be responsible to a change in pressure and frequency. Here we have a 3-peak curve with a depression curve. Each one of those 3 peaks, they have a physiological impairment. And on a normal subject with a compliance and elastance, which is normal, we have P1, P2, and P3. And if there is an increase of compliance, we have a decrease of elastance, and the N is no longer so clear. A morphological qualitative evaluation may be carried out to understand if you may have a patient with impaired compliance, and according to the curve that may increase due to compliance, or just comparing amplitude of peak 1 and 2 that usually are lower than 1. But if you have ICP or cerebral compliance, that equation is inverted and it goes up, it becomes greater than 1.2. Brain care device assesses compliance, the cranial elasticity, and then you'll be able to understand the non-invasive curve. This is a graph from a patient from our service, above with a normal compliance and below reduced compliance, and that replicates that wave, that pathological wave format. CSF pressure is directly related to ICP, directly to elastance and indirectly to compliance, but ICP is directly related to CSF pressure, right? The same CSF opening lumbar pressure takes place in terms of variability to patients' compliance. Those studies with a smaller sample do not show a sample with the levels of compliance, especially if they have idiopathic intracranial pressure. There is a relationship between CSF and intracranial ICP, age dependence, because patients' elastance increases and compliance reduces. And that is quite clear in the literature. Medication may influence patients that are taking antihypertensive drugs. They show elasticity parameters levels which are higher and reduced compliance in comparison to those patients who are not taking antihypertensive drugs, but intracranial pressure does not vary. There are some additional publications with the brain care devices showing that there is a correlation between pressure and compliance. And here we are not talking about a static patient, but mainly outpatient model. And there is an example of that, which is CSF hypotension. We have spontaneous intracranial hypotension from infusion tests, and they try to understand the intracranial hypotension invasively. That's a different way to do it invasively throughout MRI. They were diagnosed in the acute, subacute, and chronic phase. During the acute phase of the disease, intracranial compliance is increased in comparison to the whole population. And as time goes by, that decreases in relation to what we would expect to normal values. Our biological system gets adapted and it compensates to the aggression, and there is a clinical relationship to it. We know that clinical presentation, the real presentation of the disease, which is the orthostatic headache, that becomes stronger during the acute phase, those 10 first weeks, and that becomes less evident in the following weeks. Therefore, there is a stronger correlation between clinic and biological findings. Patients with CSF hypotension, after a while, they develop a thickness of the epidural meningeal portion where vessels, they become thicker, they develop fibrosis, and in comparison with normal subjects, patients with CIH with EVD, they see increased intracranial elastance in relation to those who have a decreased intracranial elastance. The system adapts to SIH, reducing intracranial compliance, correcting increased compliance, and such a compensation may be pathological. You may overcompensate it and develop intracranial pressure in the CSF. So we better see that system as a constant, as a system under constant change. Now we switch from intracranial pressure and we reach a variable with a number of aspects that may influence its results. When I say that that is dirty, I mean that it may interact to a number of additional biological factors and some other significant clinical outcomes. And this is the compliance definition that is part of a incipient literature. And we believe that once the way we see compliance becomes less invasive and more practical thanks to the new brain care devices. Patients with normal pressure hydrocephaly, they may undergo a shunt placement. Some will improve, some will not. And intracranial elastance before the procedure, they will have increased levels and they'll have a higher likelihood to improve their outcomes. Regular hydrocephaly as a consequence of primary stenosis, which is a cause of hydrocephaly for those patients that have that CSF pressure, despite the initial ICP is not well correlated after the surgical procedure, there is a correlation and it works as a prognostic marker and a variable that might be used for surgical indication and which patients will be more eligible for that therapeutical achievement. In addition, we want to improve the diagnosis. I said that part of the population with no CSF, they will have some thresholds, 20 to 25 millimeters alteration that will lead to some diagnostic misleading. Well, patients with idiopathic intracranial hypertension, they are submitted to a reference center, but 1/3 of them, they have a misleading diagnosis. Some of them had even been submitted to a operation, but that was not quite the case. As I said, there is an individual correlation between compliance, ICP, but that is not a linear correlation as there is a significant variability. On the other hand, compliance has a stronger correlation to the diagnostic aspect. Patients, they have decreased compliance, increased elastance. Therefore, this variable compliance and elastance may be very helpful to close the diagnosis. And not only in addition to help to close a diagnosis, that variable may help us to better understand the disease. As to spontaneous intracranial hypotension without CSF leakage, part of those patients, they don't have ICP reduction. That might be compliance due to customization of the system. It might be the case or not. And moreover, some patients, they have no fistula They have all the clinical and radiological findings, but without CSF. Could that be a primary compliance disorder associated to some features to the compartment that surrounds that CSF compartment? Well, that is possible, and once we better understand how compliance and elastance behaves daily in the pathological and normal group of patients, that may enlight our future pathological findings. That's it for now. And let me just reinforce that none of that would be possible without Professor Mascarenhas. He was a genius, smart physician who allowed the development of a device like that, that helps us to better understand the behavior of compliance and elastance, and supports a better way to manage treatment and to better diagnose our patients in our clinical practice. Thank you for now. This is my contact information.
Thank you very much, Dr. Gabriel, for your excellent presentation. Compliance is really something about which studies will direct and show us that the efficiency of the measure of morphology and a wave of ICP and studies correlating everything. We still need further studies so that we can effectively say, even when we look at the curve and morphology, and even though we do not have absolute values of intracranial pressure, we can correlate it with compliance, obviously associating other variables as we've mentioned here. So, from your perception and in your experience, what is the level of reliability when we look at wave morphology, and to be confident in terms of saying that the compliance is affected? Well, actually, this is the focus of our studies at the Clínicas Hospital, and we are assessing the correlation of wave morphology with pressure variables as well as with compliance variables. And so for now, I don't really have a fine impression that has been formed. And there's a limitation in knowledge in the area. So we have patients at acute phases of the disease with absurd oscillations in intracranial pressure in the ICU. But usually these things are more adaptable. Systems adapt themselves. The feeling I have is that classical parameters that we have been using for curves are not as applicable or as easily applicable for outpatients. But in our understanding, curves are different between patients that have patients that do and do not have a compliance curve. What we're still missing, we need to study the parameters to identify the best parameters in those conditions. Another thing that I find important is that our gold standard is pressure, has always been pressure. But what I question is whether this is a good gold standard. Is it, in fact, the best correlate for compliance? And when we look at hard clinical outcomes and we forget pressure and we look at the diagnosis of intracranial pressure, wouldn't there be anything with a stronger correlation? That's more where we are going towards, in my feeling. What we've been working is to correlate both pressure and compliance, these two variables that are biomarkers in essence, and also correlating it with clinical diagnostic findings of those patients. I think that the results are going to be very interesting in this area. Well, great. We have some other questions but I am going to give the questions to Dr. Kubota, and he will be able to answer them later on. We are 12 minutes late, and we are really on a tight schedule. Thank you very much, Dr. Kubota. I will send you the questions on the chat, and we are going to move to the next presentation. Well, thank you.